we have a next session coming up with Rejiv. Rejiv, you are the last man standing between the audience and the lunch, I believe. And he'll be talking about the learnings in the management of advanced non-small cell lung cancer, 2023 and of course 24 on immuno-oncology.
Good afternoon. After all the high-level discussion that we had in the morning, my job is very easy, just to culminate everything and tell my thoughts. And before I start, I thank the ICON team, Dr. Purvish sir, because the first poster presentation I had in ICON 2006 as a postgraduate, and fittingly I am here on the 50th ICON, and I thank, because that was the first one of the first presentation for me, and I vividly remember that. So the topic I am giving today is my learnings in the management of advanced NSCLC. So we look at the immunotherapy landscape and the practice-changing trials which happened, their updated results, and the clinical factors which influence the response to ICI. And I think a lot of discussion happened whether when to use ICI monotherapy combined with chemotherapy, and even in advanced disease in case of oligoprogression, when to use local therapy like radiation. We will look at a few of the challenges we face in second line after we use ICI, and also the newer immune-related adverse events we are learning every day, and just a look into the future. So we know that NSCLC is not one disease, and at least in the majority of the patients who have a molecular target, we are pretty clear, and even the last panel showed how much clarity we have got and how much options that we have when you have a molecular target in advanced NSCLC. And we also know that though after a lot of discussion that though PD-L1 is not a ideal biomarker, it shows that it benefit a relevant subset of our patients, and that data is quite robust. But then we are in search for patients who does not have a target to look at the ideal biomarker, be it the immunogram, the mutational landscape, or is there any individual genomic variations like EGFR which will detect that the immunotherapy may not work, and of course the Tregs and all the other biomarkers which are work in progress. So the basic idea in the clinic for me would be how to choose IO monotherapy, whether you're looking at chemo plus IO or IO-IO combinations. We know that the PD-L1 will be done in 100% of our patients who does not have a target. And then we look at the tumor burden and tumor mutational burden. Of course, the patient preference as well as the patient factors, which will also decide your treatment decision in your clinic. So when you look at the Keynote 024 trial update, which was quite a 60 months update we have, and the overall survival and progression-free survival, which was published in 2020, it shows that there is definitely a benefit, but benefit from the IO monotherapy, we will know that is limited in PD-L1 low, or is quite limited in PD-L1 low or intermediate expressors, which again we debated upon. So if you look at the Cochrane analysis of the survival analysis of IO versus chemotherapy and PD-L1 expression, we know that the PD-L1 less than 1% is where we know that there is a problem, and PD-L1 more than 50%, we mostly know that IO monotherapy will work, and it's a combination in all the other cases. So again, this is an interesting data which looked at pembro benefit, which may be restricted to PD-L1 positive and who has a high tumor mutational burden. Again, in the clinic, I think we face this situation where we have PS2 to 3 patients or elderly, which again, most of the trials did not include. And if you look at the IO data, this is the Ipsos trial of atezolizumab, although the numbers are not very drastic or convincing. But this is one option which we can use in a performance status 3 patient where you are out of your platinum or any sort of chemotherapy. And at least we know that the side effects that we give to these poor performance status and elderly patients is not that much difficult, and it is possible that they tolerate. So after a detailed discussion, that might be one option for us to add in this difficult to treat patients. Now when I come to the chemotherapy plus IO, again we had a lot of discussion. So PD1, PD-L1 combos may enlarge the benefit. So if you look at the non-squamous cell, we had the keynote 189 and the squamous cell keynote 407. And the keynote 189 update, which was up to 4 years update, then it showed that even in a PDL1 less than 1%, we had some role of adding immunotherapy to chemotherapy. So if you look at the keynote 189 in more detail, the pembro plus chemo showed the 3-year efficacy benefit across PDL1 expression. But if you look at it carefully, the most of the benefit was driven by the high PDL1 expressor. So if chemo pembro in PDL1 negative non-small cell update, if you look at, there is marginal progression-free benefit, and if you look at the pooled analysis, again you can see that compared to chemotherapy arm, there is a marginal benefit of adding IO. So where are we in as far as the novel agents or the phase 3 trials in the PD1, PDL1 inhibitors in advanced NSCLC? There are a large number of trials which we are looking at, and the data yet to mature. And if you look at the 2022 data, there are a lot of novel agents in development by class, which will help us in very near future itself to decide on the combination which will help us. Whereas again in the clinic, there is a discussion on which IO is better. Is there a head-to-head comparison between IO? So there is some data and some data coming up that some of this IO may be slightly better than the other. So this was a PERLA phase 2 trial which was presented this ESMO, which looked at dostarlimab plus chemo versus pembrolizumab plus chemotherapy. Too early to tell, but it may be one way to look at it. Another way is we know that IO alone will work in PDL1 more than 50%, but whether you should use IO plus chemo combination here also, the initial data shows that it may not be such a good idea, because IO itself will do the trial, but more risk stratified and a predictive signature based trials are ongoing. So these are the trials we'll be watching out for, the Insignia trial and the PERSEID trial, where even in the PDL1 more than 50% with more robust biomarkers, will we know that chemo immuno will do better than IO alone. When we look at the IO alone versus chemo immuno data in tumors with PDL1 1 to 49%, the data is slightly more clearer. And if you look at the IMpower 151 trial, we know that which included the EGFR ALK subset, which was around 53% of the patients who were EGFR or ALK positive, they did not have much benefit. So again, which shows that most of the benefit may be driven by the EGFR ALK wild type. Whether to use IO, this was also discussed. So if this is the Checkmate 227 trial, the 6 years update, which was presented in this World Lung Cancer Conference. So again, significant benefit is seen across the PDL1 subgroup. So this may be one way to go. And you can see that this patient, we are worried about toxicity, but some of these had more than 75 years of age, and both the tumor histology was involved, and there was some benefit in across the subgroup. Another worry we have is about the treatment-related adverse event. Yes, nivolumab, ipilimumab will have slightly more treatment-related adverse event, mainly the immune-related, compared to chemotherapy arm. So this was the Checkmate 9LA study design, which looked at nivo plus IP plus chemo versus chemo, and this was stratified by PDL1 less than 1% or more than 1%. And if you look at the updated overall survival, there seems to be a role for IO plus chemo, and this was again presented this ASCO, the 4-year update of overall survival on all randomized patients. IO plus chemo seems to be working, and it seems to be working across the subgroup, especially if your PDL1 is less than 1%. So this trial also, the Checkmate 9LA, looked at advanced non-small cell lung with the brain metastasis. So if you have a baseline brain metastasis, maybe IO plus chemo may be better. Again, the side effects are slightly more, but most of them were manageable, and many of us in the clinic worry whether if you stop these drugs because of the immune-related adverse event, what happens to them. So this was an interesting data that was presented, which looked that among patients who discontinued, there was a subset of patients with 27% of patients being alive and treatment-free after discontinuing the study therapy. So we can be pretty sure, unlike chemotherapy where we think that all the cycles has to be completed to get the maximum benefit, here there is a subtype whom we have to stop because of the adverse event who will still derive the benefit. Poseidon trial was another important trial which looked at tremelimumab, durvalumab plus chemotherapy. Median follow-up was 46 months, and there was improvement in overall survival based on histopathology. I think in clinic, again, the common scenario that we face is what happens in second line. So in the studies have shown that 50% of the patients do not go and receive the second line therapy in the best of the centers. So if somebody whom we are treating because mainly of logistics reasons to only chemotherapy and then they progress, then we have data to fall upon anti-PD-1 monotherapy in pretreated patients. We have data from Checkmate 017, Pembro data of Keynote 010, and OAK data from etazolizumab. And some of these trials, even if you have not used IO in the first setting, you can see that 5-year overall survival of 15 to 20%. So some of these patients whom we use IO monotherapy in the second line, they also go on to get the benefit, and sometimes they become long-term survivors. So after first-line IO, this was also nicely discussed in one of the panel, the concept of oligoprogression we need to be considered, and there are different characteristics of oligoprogression and oligoresistance, and that has been proven that if you treat them locally by giving radiation for the oligoprogression site, there can be improvement in survival. Whether we can re-challenge IO, so once we know that many of us will be using IO in the first line, so if you re-challenge IO, this was an interesting pooled analysis of re-challenging pembrolizumab across the trial, and that seems to be working, and there is some data to say that you may at least get some good partial response even in patients who we re-challenge with IO monotherapy when we have used IO in the earlier setting. But we know that ADC, like any other indication, would be the way to go, or anti-angiogenic compounds or cellular therapy. So there was some data presented about ADC, that is the TROPION-Lung1 trial, which we used Dato-DXd versus docetaxel, whom patients who have already received anti-PD-1 therapy. And there seems to be some improvement in median PFS, but the OS data is not mature. But we need to know that the adverse event to watch out would be mucositis, stomatitis, pneumonitis, because we have already exposed them to a PD-1, and then we are going to use ADC. But all is not rosy in the second line setting. We know that there's a lot of negative trials. We have recently got in January we got update on sacituzumab govitecan, which has been negative, and the tuzamitamab data also, the Carmen 2 data also compared to docetaxel was negative. So we have been busy looking at the hematological portfolio and CAR-T, but lung is also fast catching up. So this was a phase 1 trial which shows that there is some data to use CAR-T in phase 1 trial, and I'm sure in the next few years we will be discussing CAR-T in solid tumors like lung cancer. So my take home and what I have learned in 2023 would be that we need to look at the PDL1, and if PDL1 is more than 50%, monotherapy may be the way to go. We need to watch out for data of chemo IO there. Dual IO combos may work if you have a PDL1 negative subset, and of course each patient is different and we may have to have different treatment strategy to them. And multiparametric predictive biomarkers are required for our personalized IO approach. Second line treatment, as we all know, is a challenge in the clinic, and we may be re-challenging IO in some of these patients who have received first line IO. And CAR-T and other cellular therapy may be the way to go even in lung cancer in the future. Thank you so much.
Any questions? So thank you, Rejiv. I think you covered almost all the newer advances in the immuno-oncology, including the CAR-T.